Good afternoon, ladies and gentlemen. You're all very welcome here at two, even you, Councillor Wilmot. You're all very welcome on Wednesday, the 13th of March, to the Health and Wellbeing Board. It's a packed agenda this afternoon in that we start with a formal board meeting with a number of joint strategic needs assessments, which we'll be dealing with. But then at 3:30 we morph into a presentation by the ICB for Nottingham and Nottinghamshire about their joint forward plan, and that's very important in that it dictates how they are going to address their responsibilities to the agreed strategy that we as Nottinghamshire and Nottingham have with them in order to drive the preventative agenda, to lower health inequalities and to work in partnership together. So a really, really important 3:30 to 4 o'clock presentation, separate from what we're about to do. In terms of what we're going to do today, there's three items 5, 6 and 7, and they're joined together because the building blocks of health are really the core of what we're looking at, what makes healthy and sustainable places. And two of those are food and fuel, and therefore they are all three parts of the same thing, and therefore we will run those as one item and then take questions at the end, etc. So that's how we're going to do it today. So once we get past the Chair's report, 5, 6 and 7 will be one item. Then we'll go to the Better Care Fund work programme, and then at 3:30 on the dot we should be ready for the ICB presentation. Fantastic. Right, I'm going to start off with apologies for absence, and I'm going to say that apologies for presence, even that the chair of the board acknowledges the appointment of Lee Adele, Programme Director for Bassett Law Place-Based Partnership, to the board, replacing Victoria McGregor Riley. Lee is not here today, but is replaced by Eric Kelly. Eric Kelly, fantastic. Martin.
Yep. So apologies from Councillor Tom Smith with Councillor Scott Carlton substituting, and also apologies from Mel Williams, Colin Pettigrew, and also from Helen Smith. We've got dual language here on her behalf.
Fantastic. Declarations of interests by members and officers. If anyone here present has either a pecuniary or non-pecuniary interest in any of the items to be discussed this afternoon, this is an excellent opportunity to make that known, or if something becomes obvious throughout the course of the afternoon, feel free to interrupt us and tell us. I take it that nobody has anything to declare. Fantastic. And we're going to go on to the minutes of the last meeting. The minutes are for noting the accuracy of the minutes rather than for discussions about the minutes. And I have already had an eagle-eyed observation from Councillor Tideswell. And before I go through the pages officially, I'll draw your attention to page 5 of the document and page 3 of the minutes. You'll see that in the first paragraph under item 6, it says that actions like this build on the government's plan to ban the sale of cigarettes to 14-year-olds. Well, the government didn't have to ban cigarettes sales to 14-year-olds because it doesn't exist. What it in actual fact meant that nobody who was 14 years of age on that date would legally be able to buy cigarettes, with the ban coming in on the 1st of April 2027. So by the time they got to that age, the age they were at would be in the age of being banned, and that age would increase 1 year every year consecutively, such that anybody born before that would never legally be able to buy cigarettes. So we're going to change that at some stage and redo that. Yeah, fantastic. So Susan. Martin, can we address that? Fantastic. So I'm going to start with page 1 of the minutes, which we shall address. Page 2, page 3, page 4, and page 5. Page 6 and page 7 and page 8. If there's any other noted accuracy items, I'm happy for you to declare. No? Fantastic. Can we note that? Yep. Excellent. So we're going to briefly have a brief chair's report because there are other things coming down the line, and it's just one of those things that I suppose in the next week or two we may be interested in the fact that measles has reoccurred in East Midlands, and typically on a year the UK might have 100 cases, and I think last month there was way over 200 in 1 month alone. The importance of that is that measles is highly infective. When COVID was here, we all understood the importance of vaccination. People queued for vaccinations. People volunteered to vaccinate other people, and they understood the importance of vaccination in prevention of disease. COVID itself was reasonably infectious. We all suddenly sat around the TV in an evening and we used to understand what the R factor was, the reinfection rate. Everybody would be able to tell you, oh, it's below 1 today or it's above 1. That means that if you have one person infected, they would infect one other person. Measles has a reinfection rate of 15. So you've got 15 people in the room with one person with measles. Every single one of them will get measles. That's how infectious it is as a disease. And although we were brilliant at COVID, the other vaccinations have slipped away. So our MMR vaccinations, which need to be over 95% to get herd immunity, are dropping in some instances to 85%. And that not only makes the person vulnerable who hasn't had the vaccine, but it makes those people who can't have the vaccine, those people who have immunological problems where they don't seroconvert after having the vaccine, or for one or another reason cannot have it, makes them particularly vulnerable and causes significant illness, encephalitis, meningitis, deafness, etc. So it's a great time for us to focus on pushing the importance of vaccinations and the 2 vaccinations of MMR, etc., through public health, Viv, to encourage people to get back to vaccinating their children for whatever reason that they don't vaccinate them. There are specific groups who are particularly reluctant to do so. There are a number of people who believe that the MMR should be given in 3 separate doses: measles, mumps and rubella, because that can often happen in Europe and places like that. There's Andrew Wakefield's paper in the past where he talked about autism, which has long since been dismissed as nonsense. So again, measles, it's on its way here. Great opportunity to reinforce the importance of childhood vaccinations in our children at every opportunity going forward. In terms of the document itself, there's a lovely item at item 2 where we're investing 875,000 into place-based partnerships, north knots, mid knots, south knots, going directly into those areas with the greatest of needs to build the community teams to give us our preventative agendas going forward. Places like the Bellamy Estate, which Dr. Bartholomew's will be well familiar with, up in Mansfield. So that's real money, 875,000 from the public health budget going directly into those places to boost place-based partnerships, and that's exactly what we want to see. That's exactly what we're here to see. How, in reality, are we actually bringing about change? And that's an excellent example of it. I'm going to jump forward a little bit. Can I just ask you a question about that issue? Not at this moment in time. The place-based partnerships. We'll come back to that. Right. Let me finish my little, and then
going through the whole lot first?
No, I'm only going through a snippet, and then we'll open it up. So I'm going to just have a quick jump forward to one other area which caught my attention, and that is around the sleeping of babies and the lullaby trust, etc. One of the things that exists is safer sleeping. And in Nottingham, probably 6 babies a year at least die from sudden infant death syndrome, which is the unexpected death of a child, generally under 9 months of age. And the child, it's sudden, it's unexpected, and the child is previously healthy. They're the type of things that distinguish that. And the big push at the moment is through sleeping advice, through our family hubs, etc., to encourage patients to put babies on their backs. There was a case where in time gone by, not that many years ago, we were always encouraged to put babies face down. And therefore it is an about turn. And it's thought somehow if you put your baby face down, that their head is pushing into the clot, and then instead of breathing in oxygen, they're rebreathing exhaled carbon monoxide, and they think that may have some element to play in it. But that's a big push at the moment to reduce sudden infant death syndrome in the community by pushing out safer sleeping and educating parents, particularly about having babies in the bed with them. 60+% of deaths occur with the baby in the maternal bed, and sometimes that's associated with smokers within the household. And obviously educating parents, don't put the baby in your bed if you've been out drinking for the night. Don't put your baby in your bed if you're on tranquilizing drugs that knock you out overnight, etc. A lot of simple advice around a very, very important area of sudden infant death in the country. Probably one parent in the country every morning wakes up to a dead baby. So we're pushing forward with that. And one last item before I go over to you, Councillor Wilmot, and it's about smoking. And it's interesting that item number 56 talks about smoking cessation. And what better day to do smoking cessation than today, which is non-smoking day. Today, the second Wednesday of March, is now traditionally, used to be Ash Wednesday, but they've moved it to the second Wednesday. Today is no smoking day, where people traditionally get that little boost where they say, today is the day I will stop smoking. And it's obviously a day that we want to get that message out there to as many people as possible, that smoking is still the biggest killer, the biggest causes of cancer, the biggest causer of ill health that exists out there, with at least 1 in 2 smokers dying from the effect of smoking itself. And we do have a number of programs out there, from the Intent program, where we're in schools teaching people about the dangers of smoking and vaping, through to our ABL service, A Better Life, where we're actually giving smoking prevention, etc. And it's an important day to just reinforce that message to people that we want to get to a smoke-free Nottinghamshire. I'm going to, was there anything in particular, Tillen, that you wanted to pick up on there?
No.
In that case, we'll go straight over to Councillor Wilmot.
Thank you, Chair. Yeah, very, very investing in communities is a really good thing. It's an excellent idea, but I'm just concerned that the impact will be minimal across the county with the odd places that you're actually doing it. Is there, if it is successful, is the idea to move it on to other areas that need help in that area?
I think what you're seeing there is a single grant from the Public Health Department for a single sum of money. You also have to look at the 4.5 million, or 3% of the ICB budget, which has been promised for the preventative agenda. and therefore if you put all the variety of pots together, and the item after that has 170,000 which was dispensed out from public health to other areas as well. So it's a single item that has been dispensed, but one of an enormous amount of money that's going into all of these variety of places. Councillor Wheeler, did you want to say something?
Yeah, briefly, Chair, sorry for the microphone. Just to talk about the smoking prevention, obviously, Rob as well, No Smoking Day, just to let everyone know what's something done in Rushcliffe. I signed up an initiative that we are banning smoking in all our public spaces and play parks that we operate since I'm 16.
Yes.
And I think it's something really important because although people choose to smoke hardly, I would say what's really important is that secondary smoke, we know that they can't have obviously young people we don't choice to be around smoke. So if you're in districts and areas and already, or you're encouraged to following suit to that, which is really positive so far. Now that big difference to our response.
Was that through the Tobacco and Smoking Alliance?
Yeah.
Yep.
Yeah, so it's on a chance there, and I'd say really to push that issue out there wide. And like I say, it's something which we're not in a negative fact so far about something positive that people, smokers have realised that they the importance of making sure they're not. The people who don't want to be around smoke have that opportunity and that choice. I mean, that's the main thing. So we're not saying that it's not a government initiative, not a law to say you can't smoke, but just to make sure in the public space we operate that where it could impact other people. They don't have that choice to be around smoke. We want to prevent that.
Thank you, Councillor Wheeler. And of course, tracking down counterfeit cigarettes with their hundreds of carcinogenic content is something the county is doing on a regular basis, and is also now tracking down counterfeit vapes, which are an equal challenge. Could I ask Director of Public Health Vivian Robbins to contribute to that?
Yeah, thank you, and thank you for your valid points so far on that. So yeah, absolutely endorsing what the members of the board have said. We know that smoking is one of our biggest causes of preventable death, but also in terms of healthy life expectancy, in terms of that implications of people living with poor health. So really would support the work that's going across the partnership, and thank you for your contributions for that. One of the things that I would just like to highlight is that we've recently had additional investment around stop smoking, and we will be looking at how we can increase the range and the reach in terms of allowing people that feel that they are ready to make that decision in terms of looking to quit, to give them the support that they are available to do that. So we're looking forward to be able to increase the level and provision of stop smoking services, as well as that broader policy agenda in terms of how we support our young people to make decisions around what's right for them in terms of hopefully aiming not to start smoking, but also thinking around the implications of vaping, and also thinking about that wider environmental piece. So a lot of work going on in terms of the stop smoking agenda, and great to see that it's the 40th anniversary of No Smoking Day today. So yeah, great work, more. Thank you.
So that brings us back to right, excellent. So I've got Councillor Jackson first.
Thank you, Chair. I just thought it might be helpful to mention a couple of the initiatives that we've got in the Mansfield area. One really important one that I don't know if it's in the report, but I think it's important to mention is the Phoenix team at Kingsmill Hospital, because I'm on the board for Sherwood Forest Hospitals. They have an amazing success rate of getting what they call smoke-free babies delivered. So they have an excellent rate of helping women and their partners to quit. So I think that's a really good incentive and something that we should all be doing. And the second point was that up at our Bellamy Road premises, which was already referred to, the smoking cessation team do outreach work, and if I've got this right, there weren't very many people engaged, but out of 5 people that came forward, 3 managed to stop smoking, and that's actually quite good considering we're looking at entrenched long-term smokers. So it's just a couple of examples of how that strategy is working in real life. Thank you.
Yes, thanks, Councillor Jackson. Yes, I share your pride in the Phoenix programme. I think it wasn't long ago that they were celebrating their 100th person through who had stopped smoking, etc. And it's not just a package for the person that's smoking, it's a family package. And therefore, if you've got a person who goes home to somebody who smokes, if both of them are not smoking, the success rate is much, much better. So I think that's one of its more unique elements, in that it involves the environment as well as the individual. So I think that's an excellent success for Kingsmill Hospital. Councillor Gowland.
Thanks. Having heard Councillor Wheeler's work, I wondered if the county could consider making bus stops smoke-free or within 10 metres of a bus stop, because a good place to get secondary smoke is at bus stops.
Thanks very much. Have we got any plans to make bus stops smoke-free zones?
I would need to double check with people who know further detail. Obviously, we would like to make the whole of Nottinghamshire smoke-free. We're going to have to take that one step at a time, but certainly we can look in terms of what options there are available with that.
Councillor Wheeler.
Thank you, Chair. I'd just like to say that actually Gedley designated all its play areas as smoke-free back in 2015, which is quite some time ago actually. But my comment is around the government talking about smoking and vaping, but there's no bill as yet been published around making those initiatives reality. So, for example, the issue around the age, I think the government needs to really step up in terms of publishing the bill. I was just wondering what the Health and Wellbeing Board could do in terms of, sort of pressurising the government to do that, to bring a bill forward, which would help for those things it said, because I think it's really important that we tackle the issues around health, particularly for a lot of the young people that are taking up vaping, but more generally speaking, in terms of making it the reality that the government wants, which is like smoke-free UK. Thank you.
Yes, and if we live to be 100, we would never ever achieve anything in our lives that would come close to the impact of stopping people smoking, such as the impact on life and health, etc., that it is the single greatest thing that we can strive to achieve. Going to a smoke-free Nottinghamshire and a smoke-free UK, and depending on legislation, has many hurdles to go through yet before we ever get that even signed into legislation. It can be changed by somebody, as in New Zealand, which signed legislation, then had an election, then the leader changed, and then they actually changed the legislation because there was £1 billion of tax that came in from smoking, and the new government thought that £1 billion could be better used to improve the health and well-being of the population of New Zealand than actually the smoking ban would have. So we have many hurdles to cross yet, Councillor Wheeler, but I would love to have the ability to go down and demand it. Yes.
The reason I'm saying that is because obviously Ash had quite a good campaign recently where quite a lot of councils cross-party signed a letter to Rishi Sunak, to the Prime Minister, to hopefully press him to bring a bill forward, which would hopefully make all those things that he's talked about a reality. Thank you.
Thank you, Councillor Wheeler. Yes.
Councillor Schuler.
Councillor Schuler.
Just building on what fellow councillors have said, Chair, that about the tobacco declaration. We in Bassett Law re-signed the tobacco declaration last year, and our parks are all smoke-free, and as are our buildings. And we have also further lobbied Parliament about the fact that young people can be given vapes, or even though they cannot buy them. So we advocate the tobacco declaration, and we'd implore all councils to sign up for the tobacco declaration. And we have today agreed to share with our economic development team the tobacco declaration, so that it can be shared across all of the business providers that we have contact with.
Thank you, which epitomises the essence of everything that the Health and Wellbeing Board is about, and the Tobacco Declaration is about, bringing it back to your organisations and the place where you have some influence in order to bring about change. I think if we can all do that, it would be brilliant. I'm going to move on because this afternoon we're going to put together the items of 5, 6 and 7. I'm going to say item 5 is the building blocks of health. Item 6 is approving the joint strategic needs assessment for food insecurity, and item 7 is the approval of the joint strategic needs for fuel poverty. And the building blocks of health are exactly as they sound. If you go out into healthy and sustainable communities, what are the basic requirements that are needed in order to have a healthy, thriving society? And it's a visual metaphor that we can all easily see.
Apologies. I'm going to hand this over to Dawn Jenkins to lead this agenda.
Dawn Jenkins,
That's okay, please.
take it away, Dawn. Dawn, before you start, are you going to do all 3, or are you going to stop and...
So I'm going to present building blocks, and then Carol Ford present food insecurity and fuel poverty
together?
and
And then what we're going to do is present them all as one, and then we'll take questions, and then we'll do recommendations, etc. at the end of that. Carry on, Dawn.
Thank you so much, Chair, and good afternoon, colleagues. I'm Dawn Jenkins, Consultant in Public Health at Nottinghamshire County. Today I'm going to give you a very brief introduction to the building blocks of health, and you have a paper in your pack for the board today which goes into a lot more detail about the concepts of the building blocks of health. This directly relates to Ambition 2 of the Joint Health and Wellbeing Strategy for Nottinghamshire, which is to create healthy and sustainable places. So this is all about the places where we grow, live, work and age. And research tells us that this isn't the first thing that people think about when they think about health. So when people have been asked, actually, what does health mean to you? The first thing that comes to mind aren't the places that we live and grow, our surroundings, but actually the first thing that comes to mind is the NHS, and then secondly, our individual responsibility to take care of our own health. So that's what research has shown people think about when they think about health. But in reality, we know that research has also shown us that health is really present all around us. The factors that have the biggest impact on health in our communities over the life course are actually the things that are happening in the environment all around us where we grow, live, work and age. And therefore health is happening all around us every day. But it's really easy for that to fade into the background and for us to ignore all of those factors that have a really significant impact on health. So why does that matter? What surrounds us actually significantly shapes our health. Research again from the Health Foundation has shown us that as little as 10% of the population's health and wellbeing outcomes are associated with access to healthcare. So what about that other 90%? Well, we know that it's related to things like having a good job, being in employment, to having a home, a place to call home, and to having access in your local area to healthy and affordable food, as a couple of examples. So we know that those aspects are both really, really important to our population's health outcomes, but also really easy to fade into the background and take for granted. And actually what this leads us to is taking an approach to health that is seeing health as an asset. So rather than being something static that we either have or we don't, health is something that we can build on and strengthen throughout our lives. And we can do that if we have the right building blocks in place. So we can think of health as a metaphor. We can think of health as being building a sturdy building. And what we need are all the right building blocks in place, like having a secure job, good housing, and access to food. We need those building blocks in place in order to achieve the quality of life and the length of life that we aspire to for Nottinghamshire residents. Unfortunately, for too many of our residents, those fundamental building blocks are damaged or missing altogether. And the result is that lives are being cut short because of the lack of those building blocks for good health. And in Nottinghamshire, we know that's as much as 7 or 8 years of life lost, and an additional 14 years lived in poor health as a result of not having these fundamental building blocks in place in our most deprived communities. So clearly, as a board which has a remit for improving the health and reducing health inequalities for Nottinghamshire, this is an important area that we need to consider and focus on. And hence it is one of the 4 ambitions of the Joint Health and Wellbeing Strategy. So we need to consider together what impact these building blocks are having, and understand a lot more about how those building blocks are impacting on quality and length of life for our residents. And crucially, to identify together the opportunities to really strengthen and improve on and build health as an asset throughout life for our communities. So the way that we have approached this is we are proposing to the board that we make a start with a framework for action, focusing on 5 key building blocks of health. So good food, making sure that our residents have access to healthy, affordable food. A safe and warm home. People will know from the Director of Public Health's annual report the impact that having a roof over your head to call your own has on people's fundamental life chances. And the condition of that home is also really important, and you'll hear more about that through fuel poverty briefing later on. Having a good job. Having a job is so important, not only for the financial security, but meaning, purpose and productivity in society. And we know that good employment leads to really important health outcomes. Keeping active is about actually the environment around us. How much does that allow people to get out there and to meet with friends, to use green spaces, to walk on a daily basis, to get that little bit of exercise that we know makes the biggest difference to people's health and well-being. And how much are we supporting people through the provision of those spaces, those safe walking routes, those safe cycling routes. And finally, being part of a community where there's abundant evidence of the importance of social connectedness, social resilience, and the huge impact that things like social isolation have. So strengthening and supporting our communities is a fundamental building block. So what we are suggesting across the rest of this year is developing a framework of action that identifies the real untapped opportunities for us to work together to improve on these building blocks. Now, I haven't time today to kind of give you more of an explanation of each of those building blocks, and we hope to come to that in due course, working with the board across the rest of the year to develop that framework for action. But I'll just provide you with one example, because it sometimes can be less straightforward to make the connection between that housing and what's the impact on health. So just one example, I could have chosen from many, but why is a warm home important for health, for example? And I'm taking the example of an older person living in a cold home. What's the impact to health? So, for example, somebody who's living in a cold home, who's an older person, may be facing difficulty to heat it because it's really expensive. So they may choose, because they're concerned about their heating bills, they may choose to leave the heating off. And that being cold actually might have a direct impact on their activity. They might choose to heat one room and only sit in that room and not move around. That means that they might have a reduction in their mobility and their dexterity and their balance. So, and they might just start to become more frail, more isolated in that cold home, at increased risk of respiratory disease and increased risk of falling in the home because of that reduced mobility. So one consequence of that is that that older person might start to experience a lot more frailty, hospital admissions, and even possibly an earlier death as a result of living in a cold home. So one solution, we'll start to talk about that more in a moment with Carol's presentation. We need to really think about our most vulnerable in the community and how are we best targeting support to improve both the energy efficiency and the affordability of energy in those homes for our most vulnerable. We also know that the building blocks of health are fundamentally interconnected, so it's not just about getting one bit right and other bits will naturally follow. So, for example, we all know the experiences of people trying to make difficult cost of living choices where the cost of their heating might mean that they're having to think about what they can afford to buy in the weekly shop, and they might start to cut out some of those healthy foods. So having a cold home can be directly impacting actually on your healthy food and your diet and your general nutrition. So that's just an example to start the process of thinking about the building blocks of health and how they interrelate. And I'm going to hand over now to Carol Ford, who will give you a presentation about the 2 JSNA profile packs that we've developed in these areas. Thank you. Just waiting for the slides.
Okay, so good afternoon. So my name's Carol, in public health, and I've got about 10 minutes worth of slides. I'm going to go through some of the key findings of both of the profile packs. I'll try to link those back to the building blocks metaphor that Dawn's just been describing. Also try and have a focus on the assets that we have locally to tackle these issues. And a bit of space to think about what additional opportunities do we think we have in Nottinghamshire on these important issues. So let's have the next slide, please, Lizzie. Thank you. So I'm just going to start with just a bit of a reminder of what we mean when we're describing these 2 issues. So food insecurity. So we don't have one single definition, one single measure of food insecurity. You might have seen in the pack there's a number of different data sets that we can go to. But broadly, it means being unable or having an uncertainty around access to adequate quality or quantity of food. There is a scale of food insecurity from the UN Food Agriculture Organization that I find quite useful, which goes from mild to severe, with mild being being uncertain about when you can access food, to severe being no access to food for a day or more. Onto fuel poverty. So generally the definition is being unable to meet your energy needs at a reasonable cost. In England, we do have quite a specific definition that informs the national data that you'll see in the pack, and that is the low income, low energy efficiency definition. So somebody is considered to be, or a household is considered to be in fuel poverty if they both have an energy efficiency rating of band D or below, and if they spend the required amount to heat the home, it takes them below the poverty line. So we've got quite a specific definition that we use there. The next slide, please, Lizzie. So just linking back to Dawn's presentation then. So we're talking about food and we're talking about healthy homes. So these are 2 of the key building blocks. And we need all of those right building blocks in place for everyone in Nottinghamshire to thrive. And I think what we see through those 2 insight packs is that those blocks are missing for a number of residents. Let's have the next slide, please, Lizzie. I've just picked out some of the key findings in the packs just to highlight this. So looking at food insecurity, so it was estimated in June 23 that 110,000 households in Nottinghamshire would be experiencing some level of food insecurity. It was also estimated that over 38,000 adults were not eating for a whole day, so that's that severe end of the experience scale. And for fuel poverty, it's estimated that 13.6% of households in Nottinghamshire are experiencing fuel poverty. So that's where those blocks are a gap. The next slide, please, Lizzie. Thank you. It's not experienced equally, so you'll see in the packs that we've identified particular population groups that are at high risk. In the box on the left-hand side, that's identifying the groups at high risk of food insecurity. On the right-hand side, fuel poverty, and you'll see there's a huge overlap there. So we're identifying those on a low income, households with dependent children, people living with disabilities, and minority ethnic households cross over both. It's also identified single parent households as the household most likely to experience fuel poverty. There are, of course, some geographical inequalities as well, and they're articulated in both of the packs. If we just highlight one or two of those now, if we were to look at both of those measures by district and borough, the percentage of people living in areas at highest risk of food insecurity is far higher in Mansfield at 53% compared to 19.5% across the county. And likewise, if we look at the fuel poverty measure, that's also highest in Mansfield at 16.2% compared to 13.6% in Nottinghamshire. There's a lot more detail in the pack. That was just highlighting two of those geographical inequalities. And the next slide, please, Lizzie. And just to think about one of the impacts, there's many impacts that we could consider today around food insecurity and fuel poverty. I just wanted to go kind of step by step through one example if we were to think about young children. So if a young child is experiencing food insecurity, that might mean that they're tired and they're hungry. If a young child is tired and hungry, that might impact their development. If a child has delayed development, this can lead to poorer educational attainment. And one consequence of this would be poorer employment prospects. In the JSNA Insight Pack, you'll see one of the recommendations is this solution here to increase the uptake of the evidence-based targeted national schemes, things like free school meals, the Healthy Start cards, the HAV. But we could have chosen many different impacts just for children or other population groups there. It's just to give you a flavour of that explanation. And the next slide, please, Lizzie. So thinking about some of the assets that we've got in Nottinghamshire, so both of the packs try to articulate what we know about what we have and what we can build on, kind of locally and nationally. Just going to highlight a few of those now. So on the food insecurity agenda, we've got some really strong networks and partnerships. So we've got the Nottinghamshire Sustainable Food Network. Each district and borough has a food partnership that brings together those local assets. We've got the Food Charter for Nottinghamshire, which was endorsed by this board, I think, in 2022, which articulates our ambitions. And we've got the Good Food Pages, so we've got some good resources for Nottinghamshire and lots of interest and activity. We've also got the commitment to develop the food plan, and like I mentioned in the last slide, those national schemes that we commit the most of as evidence-based schemes like Free School Meals, Healthy Start. So lots to build on the food agenda, I think, locally. Thinking about fuel poverty, I've just picked out a few of the local schemes that we have. So we have the Nottingham Energy Partnership Healthy Homes Service. So they offer information, advice, guidance, signposting around warm homes. We've got the County Council's advice on keeping warm. So we issue a winter warmth booklet, and there's information on the website to signpost for information. Age UK have a warm homes programme. And just to mention grants that have been issued through the Local Communities Fund. So there's grants to voluntary and community sector organisations supporting the food agenda that were mentioned in the papers in the Chair's report. So there's more in the JSNA packs, but there's a lot to build on locally, I think. Okay, have the next slide, please, Lizzie. Okay, that writing might be a little bit small. I've just tried to pick out some broad opportunities for health and wellbeing partners, and also some of the specifics in the recommendations in the Insight Packs. So I think there's some broad opportunities around understanding and really championing these agendas across our organisations, using the JSNA findings and driving action on the recommendations. There's some specific support I think that we'd ask for around socialising the food charter and supporting the development of the food plan, and thinking about how that agenda sits within the Health and Wellbeing Board. So there's an ask, I think, around strengthening the governance of that food strategy group. There's also those opportunities I've mentioned around increasing uptake of the national schemes. In terms of the fuel poverty pack, there's two core recommendations in there. One is about supporting the development of a housing stock database, and this will be across all district and boroughs and the city. And this is around really building our understanding of housing stock conditions, so it can help us really target interventions and understand the need better. So that's something that's in the early stages at the moment. And then more broadly, just opportunities that we have across our partners to make the best use of the schemes that we've got, so kind of increasing the uptake and targeting appropriately. So that pretty much reflects what's in the recommendations. So this is the last slide from me then. So just the overarching, I think, ask of the board and for the discussion. In the papers, we're asking to approve both of the packs and for consideration of how we can promote the findings and support the recommendations. But I think it would be really useful to have a conversation around what other opportunities do we have across health and wellbeing partners to have a greater impact on both of these important agendas. Okay, that's it from me.
Thank you. Yes, recommendation to approve the draft Health and Sustainable Places Framework for Action, further development with partners. Vivian, that's for our Healthy and Sustainable Places, item 5, and this is for items 6 and 7, to approve fuel poverty and fuel insecurity during strategic needs inside packs, considering the role of promoting the findings, and consider further opportunities across the Health and Wellbeing Board partners for greatest impact. And I think it's one of those things that we've probably heard quite a lot over many years, and indeed you just go back to 1991 when Dahlgren and Whitehead brought out their picture of the rainbow diagram, which had us at its centre, and the uncontrollable facts of how we are born and our genetics, but the more important factors in the houses we live in, the jobs we've got, the housing we've got, the opportunities we've got, our lifestyle choices, smoking, drinking, weight, etc. And that, I think, was one of the early idea that health doesn't exist in the doctor's surgery, that 90% of it, as you rightly said, exists outside it. So we knew that it all existed outside it, but we didn't at that stage necessarily have any sort of model to put into place that would harness the knowledge we have to use it to reduce the health inequalities and shorten life expectancy of the population. And then it wasn't until 2010 that Marmot talked about fair society and healthy lives and showed how it could be implemented across society. And I think the idea through the ICS and through the preventative agenda and through our health strategy is to harness the knowledge that we've known for 30 years, but haven't necessarily in a designed manner sought to influence it in the places in which it caused the greatest problems, in the communities, in the houses and in the homes. So this is exactly what Dawn and Carol are projecting today, is how we can harness what we know to improve health inequalities and improve the healthy life expectancy and life expectancies of the population. I'm going to start with Councillor Gowland.
Thank you. I've been on this committee for a few months, and honestly it feels slightly like the Emperor's New Clothes. Last month you told us about the Marmot report, or the follow-up to the Marmot report, which told us that 1 million people have died in the last 10 years because of poverty. This month we learn that 13.8% of our population are in food insecurity. 38,000 people are not eating. 38,000 people are not eating. That is not a choice. That's not due to, things that people are saying in the media about people. This is people choosing not to eat. They're not being able to eat. I respect everything we've been told, but with no offence to anybody in their professional expertise, my grandmother grew up in the slums of London. She understood that poverty, food deprivation, and lack of heating cause ill health. This is nothing new. We all understand this. So what are we going to do about it, right? I think that's the question. On page 55 of this report, East Midlands has the highest food insecurity. Maybe we should be writing to the government to point out that we have very poor population here. I look at page 33, which talks about the outcomes from last year, and honestly, they're not measurable. Rather than talking about physical activity, and I'm really sorry to the officers, and I apologise to everybody whose work I'm talking about here. I do appreciate, this is your job, but working on physical activity, shouldn't we be having activity targets that we can measure? I'm not saying we give the population targets, but if we're introducing walking paths, for instance, as an example, shouldn't we be actually working out whether they're used rather than just having introduced them as an example? I think we have to recognise fundamentally this is due to poverty, and I'm really sorry, but I have to say this. This is not a political point. It is a political point, but I'm not talking about politics of today specifically. But as an example, today, we're talking about somebody in the media who's given £10 million to a political party. It doesn't matter which one it is. Somebody in this country has £10 million to give to a political party. It doesn't matter who they are, which party it is. And that money came from public taxes, as I understand it, and other people cannot eat. This is the problem, and there's no point building walking paths and talking about heating houses. There's a problem of inequality, and that is where we're coming from here. I'm really sorry, but I had to say that.
Thank you very much indeed. I could go back and say I started medical school in 1979, and the same diseases are killing the same people in the last 40 years. People are still smoking and dying from smoking. People are still dying from drinking too much. People are still dying from heart disease. People are still dying from stroke. So that's a universal comment on life in the world, essentially. And all we can be responsible for is the trend. All we can say is that smoking since 1979 has been continually on a downward trend, etc. So what we can intervene in is the trends rather than the fact that these actually exist in themselves. Director Robbins.
Thank you, Chair. So, thank you for raising that point. The evidence base has been evolving in this area for a long period of time, and Councillor Doddy mentioned the Dahlgren and Whitehead model, which really spearheaded some of these conversations. These are complex issues, and these are not going to be changed overnight. These are things that we collectively need to come together to think around how we can really change, so that we're embedding the really important preventative approaches today and strengthening those building blocks for those communities that we know in Nottinghamshire that have those building blocks that are missing, so that they have a stronger future for tomorrow, but also from an intergenerational point of view. I think there is a challenge in terms of how do we as a health and wellbeing board take this into a so what, and how can we all collectively think around what are the specific things that we can do within our organisations to help make this better Nottinghamshire for tomorrow. So that might be things in terms of some of the great work that many of you have mentioned today, in terms of making sure that you are looking at smoke-free policy, in terms of some of the areas that you're working with. It may be about making sure that those residents that need those information, advice and guidance know where to go and are getting the support that they need. But I think what I would say is on this is I'm really thankful and grateful for the work that Dawn and Carol have done today in terms of highlighting where we are at and where those really important issues are. We want to make sure that we have reduced fuel poverty, and that we have making sure that we have good avenues for people to have less risk of food insecurity in the future. And there's some really good tangible things that I think that are mentioned in the action plan here. So I suppose there's something around, we will be looking at how we come back to this in the future with the board, and we would be really keen that if people have particular ideas that they would like to put into this framework for action, so that we can really clearly deliver some of the objectives of the joint health and wellbeing strategy, please do let us know. We can build that in so that we're prepared for that workshop moving forward. Thank you.
And of course, all on the back of the Health and Social Care Act 2022, when the government introduced the integrated care service, which is the greatest single thing I've seen in health of the population since I've been a doctor. It's brought together all of the services that we need in order to do this. It's coming from a joint strategy. Hospitals never had any interest in the preventative strategy in years gone past. Every single penny was spent on actually dealing with secondary prevention and tertiary prevention for people who were already ill, and yet we have a guarantee of, and we'll see this afternoon later on, of money going into preventative care. So this is a new world, Penny, that we're in now, and it's a world that we're enormously ambitious in order to bring about improvements in prevention and health inequality and working together. I'm going to go to Councillor Anderson.
Thank you. In our presentation, and thank you, it was very informative, Mansfield has been highlighted as an area of deprivation. So with that in mind, on page 67, where the Healthy Start update across Nottinghamshire districts table is, I suppose I'm asking, at 69% is the update for Mansfield, how can we encourage that to be higher for people to be involved in this scheme? And just one other thing, in regard to food insecurity, programmes like the Food on Our Doorsteps programme and other things like that, where people can join for £1 and it's £3.50 a week for £15 worth of food. Are families engaging with this, and are they being made aware that such schemes exist? Thank you.
So I think that what we've got here is where we're at today. I need to get the absolute ins and outs in terms of the details, in terms of how specific communities are engaging, and many of you around this table will probably know some of that more detail than I do. But I think there's always more that we can do in this space, and I think there's something around learning from where we've got areas that are doing better, to think around what approaches have worked, how are we coming out and reaching into our communities rather than expecting them to come to us a little bit. But if it's helpful, I can go away and do a little bit more digging in terms of the information and come back to you, Councillor Anderson, if that's okay. I don't know if either of you wanted to add anything else. Dawn, did you want to add?
Thank you, Councillor. I think you raise a really important point. There are important assets already in our community, like Food on Our Doorsteps, the opportunity for free school meals and Healthy Start. So we are doing work within the division, working with partners to increase the uptake of Healthy Start, and we have seen important results in terms of getting a much better uptake of Healthy Start. I think there's an important aspect of making sure that these offers are known about and understood, and people don't feel barriers to coming forward for them, because we do know that in some communities that kind of that food stigma about feeling like I don't want people to know that I need some help here. We're doing some research to understand how that's impacting on communities, and I do think in sort of at the level of local health and wellbeing partnerships, it's really important that all of these assets are out there. And now at the local community level, we're really promoting and helping people to have the best access to those assets, because it undoubtedly we probably haven't got enough in place. We're always trying to get more in place, but those assets are there, and we are seeing that there is really good uptake in those food on your doorstep and other food initiatives locally. So it is getting traction, but we can always be doing more. To make sure it's known about, particularly in our most vulnerable families.
Thank you.
Sorry, Councillor, Chair. Could I just ask, would it be possible to have a breakdown of districts and the attendance at food clubs? Do you think?
Sorry. So we don't at County Council necessarily run all of those food initiatives. So we've funded some of them through the Local Communities Fund, but we don't run all of them. But what we can do is take a look at what's in place where and what we know about what the take up is. Unfortunately, we're not in control of how things are doing. The majority of food initiatives are run independently in the community, but where we're running them from Notts County Council through the Public Health Fund, we can certainly give more information on that. That's helpful.
Yes, Councillor Anderson. It's one of those things when you look at uptake and you ask yourself, why is that not higher? And we've had it for years and years and years with health checks, that we sent out health checks to get everybody over 40 to have cardiovascular health checks, and it's stubbornly remained around 50% uptake for as long as I know. There's a certain attraction to universalism where we try and attract everybody to the same thing, but what you're sort of saying is that geographically that doesn't work, and instead of being universal, that we should be specifically targeting the geographical areas which are the lowest users and uptakers in the service to get the best results. And I think that is definitely the way forward in the future. Jonathan Wheeler.
Thank you, Chairman. A couple bits. So first of all, the Healthy Start uptake across Nottinghamshire District. So slide 27, figure 15 of the food pack. Just to look in that a bit more detail, I think it'd be helpful if we could actually have the actual numbers of people as well as percentages, because obviously I know it's wildly different between the districts in terms of uptake of that, just to give context. Just want to know what more we're doing to try to encourage people who are eligible to receive the benefit but aren't uptaking, because that's quite concerning. Well, if anyone isn't, especially with potentially up to 44% in some areas. Again, I know that could be 2 people, could be 20, but if it's 1 person, that's too many. So it'd be interesting what more we can do around. I know at the end of the day you can lead a horse to water in terms of there's always stuff around comms and engagement with the agencies who are closest to the people who are most in need and on these benefits there. And just on the fuel poverty slide, am I correct in saying those figures got to the end of 2022? First of all, sorry, before I make my point, before I go into the spiel.
Thank you, Councillor Wheeler.
The food. Sorry, I'm on the next slide now. The food poverty, the information. Is it up to the end of 2022? That's what I could read from the report, unless I misread it. Sorry, the data where we talk about the food poverty. I think most of it looks like 2022. I'm talking about the percentage of food, fuel poor households. Just everything else I see refers to 2022. I just wanted to know if that was the case. I know we're going off data on the government website, so it's when that's up to date. It's not. I'm not criticising data use. Just wanted to put it in context if it is the case.
Yes, and it is an interesting area how different people respond to different invitations, and why 2 people with the same invite you get different reactions from different people. And we noted when we were doing health checks that the more often you reminded the person that they had an appointment, the more likely they were to turn up.
Yeah.
So if you rung them, if you text them, if you sent them a letter, the more interventions you had, the more likely that person was to turn up at the appointment. If you made 1 intervention, it was low. If you made 2, 3, 4, it was cumulative in terms of getting the 50% of health checks up. Can we come back to you on the 22 data?
Yeah, I mean, the reason I'm raising that point is because I understand, obviously, we know at the time where the initial bills were, and they're still high now, where they weren't relations. So the percentages, and of course, if 1 person feel poverty, that's too many. But it's just to put that in context, if that's still the case, or where that currently is now. Because if that has gone down dramatically, obviously it's still too high. We just look at trajectory, and if it is still around that high with fuel bills, potentially coming down percentages, what they are coming down in terms of cost terms, that's, I think, just puts down to where we currently are now, what we need to be doing. Thank you.
Do you need a few minutes just to come up with?
We're okay to just come back to you on that one.
Come back to you on that.
Thank you.
I'm going to go to Councillor Wilmot.
Thank you, Chairman. Yes, it's. I'm just wondering why the that all these items weren't put together as one, because it's all identifying the same sort of problems, isn't it, really? I mean, and what my big problem is that I do think that proper early intervention schemes need to be brought in to alleviate some of the problems before they actually start. It's to create a life that everyone expects. It has to start at a very early age. We all know that a child needs a good family upbringing with parents able to look after their children and, where necessary, supported to do so. It needs a good education so that in later life young people would have a good job, so they will have money to own a decent property, feed a family with good wholesome food, and be a productive part of the community. Ensuring that low income families have access to affordable electricity and gas is crucial. It's to maintaining a warm and safe environment. Neglecting this can be a significant impact on the household. It's no good identifying the problem areas if we're not going to do something about it. Policies have to be provided to tackle these problem areas. Action speaks louder than words, and always will do. It's a serious issue when 9 million adults, that's 70% of all households, actually experience food problems and getting the right types of food, etc. That's an increase of 7% over a year earlier. Look at food bank referrals tripled over the last 3 years. It needs intervention. It's costing NHS millions through families not being fed properly. There are a number of recommendations that have been put before us. It would be good to see if in 6 months' time how many of these recommendations have been brought into fruition and how many are working properly. Thank you, Chairman.
Yes, thank you, Councillor Wilmot. Almost the exact language that we've heard all the way through to say that these are the building blocks of health. This is exactly what the whole of this afternoon is about, and I'm very much expecting that we will see intervention over the next coming months. And one of the big challenges going forward is making sure that we constantly update people on what we're achieving in the strategy on a regular real-time basis, which is exactly what you're looking for. And it's not even providing intervention from when a child is born. It could go antenatally, and it starts with the Phoenix program and stopping people from smoking in pregnancy and reducing growth retardation and spontaneous premature births, etc. So you could even go back to that first 1,001 days. Professor King.
Yeah, thank you for a very good presentation, a very interesting paper you put together as well. So my role is I'm the chair of the Voluntary Community Social Enterprise Alliance. So the thing I was thinking in terms of this is, for a start, how do we socialise and get that sort of group involved? Because I think that'd be really, really useful. So first of all, just an invitation to come to our alliance. Happy to have a chat around that. And I think it's having the language that you presented, and actually not necessarily the paper, but actually the PowerPoint presentation, to socialise it and to get people to understand that language and then think about how they can apply that in a few settings. So thinking about it within their own work, I think be really useful, but also funding applications and others. So I'm thinking not just for the organisations putting in funding, but for commissioners and others as well. So this becomes actually a joint set of understandings and practices. And we've got a third sector commissioning group and things. And I'm thinking if we can actually begin to socialise commissioners in health and in other areas around this understanding, as well as organisations as well, then actually there could be more opportunities for joint work around this. And potentially as a bit of a plea as part of that work, then giving people the resources to put that together. So some of the background data that you've got, the sort of whether there's a theory of change underlying this, and other things that could enable organisations to actually action that within their, as I say, within their own strategies, in their own work, and identifying it. Some of those things, organisations be involved in, play schemes, sports, various things like that, may not see themselves immediately as providing health outcomes, but they very much are because of those wider social determinants of health. So I think ultimately what I'm saying is there's opportunities for an education piece and a sort of funding piece that can come along with that might actually get to that, the heart of that in the long run.
Thanks, Professor King. Dawn, did you want to say something on that?
I just wanted to say thank you. We certainly welcome that offer, Professor King, and we'll be in touch to pursue the opportunity there. I think we have the unique opportunity at this point in time that we're working with the Health Foundation, which is a national, very respected independent agency in this space, and Frameworks UK, which is a research organisation that their entire work is researching how we communicate and frame messages effectively. And the research that does, evidence-based, that does underpin the building blocks of health comes from them. They are working with us as a pilot site. They've chosen us out of all sort of local authorities in England to work with us to help develop this program over the next 6 months. So we've got a real opportunity to do exactly as you're suggesting, to start to embed this into our practice. And I think embedding that way of thinking, that framing, then unlocks the opportunities to think differently together with partners about how we address those building blocks. Absolutely. And it is an ambition of myself and my team that we start to replace the term wider determinants, which might be a bit inscrutable for some people, with the term the building blocks, which we feel might be a bit more accessible, and start to have more of a conversation around that. So thank you very much for your insights.
And people understand metaphors and visual imagery sometimes a lot more than they do medical terminology, with the average reading age in Nottinghamshire being something around 11 years of age. Sarah Collis.
Evaluation criteria is understood, could be a really good part of that. So again, I'm interested in the point you made at the beginning about you're going to measure this, because actually just some effective argument for commonness about language, evaluation criteria, understanding.
Thank you, Professor King. Sarah Collis.
Oh, yeah. Thank you for that, and thank you for your report and presentation. I think the last point that you've just made is actually one of the most important, that the Health Foundation and Framework UK are working with us on this, because I think that sort of gives me a bit more confidence, if I'm honest, that a programme of work will be developed. I mean, to be honest, listening to the statistics that you've drawn together for us today, I think are really sobering. And I'm shocked and feel so distressed, if I'm honest, to understand how many people in this county are going without food and are living in fuel poverty. And to cause both of them food and fuel poverty, we're talking about poverty. And I think that is, when you look at the building blocks, every single one of those building blocks is impacted by poverty. Whether you can afford the gear to go out and be active, and you've got shoes that you can actually wear to be active, to whether you can actually go out and buy food. So what I'm really interested in from this room, which is the Health and Wellbeing Board, with representatives of partners and yourselves as officers, is how we make sure the JSNAs are actually relevant and alive in everybody's planning processes. Because I often sit here and see the enormity of the work that's put in the JSNA. That it's, you sitting in front of us with a paper that's so many pages long does not do it justice in terms of how much work I know goes behind it. But often what I suspect is that there's only so many people ever look at a JSNA. And from a voluntary and social enterprise sector, something we've advocated for years is that the sector should be looking at JSNAs, should understand where it fits within a JSNA and where their interventions fit within a JSNA. Likewise, your housing departments, the people that are developing in local government, the open spaces, public spaces, are you looking at JSNAs? Are we using it as a tool regularly? So for me, that is, speaking as the chair of Health Watch, which is here to scrutinise so many different parts of our health and care system, and picking up the stories of people that are facing health inequalities caused by poverty. I'm really keen that we aren't just a talking shop as a board, that we see some real detail in plans that start to evidence the sort of work that you've put in as a team around finding out what works, what doesn't work, what are the issues that are really impacting, in which areas. Mansfield, it's shameful to know that this is what citizens in our area are going through, and we as collective, as a partnership, need to be looking at how we can work around that. I thought that the example you gave as the older woman with frailty living in a house is great. We need examples that expand on that, because one of the solutions, yes, is getting us some better quality insulation and looking at other things. Where's her benefits check being done? Who's in there doing her welfare right? Is she being isolated and lonely? How is she being connected into services around that? Food and fuel poverty are not done in isolation. They're not the only thing that somebody will be experiencing. If they get one, it's a gateway to a whole other load of pain that they're going through. So I think when we start to look at this framework and working with the Health Foundation particularly, I really would like us to see that every single member of the Health and Wellbeing Board has got a routine to show how they've had some impact in making change. Because otherwise we're just listening and saying how awful it is, but we need to be seeing some real change.
Thank you, Sarah. The format at which we were developing the Health and Wellbeing Board, although it has its challenges, where we've been presenting information and then following them up with a workshop. So we've been delivering the joint strategic needs data to people, and it's available on Nottinghamshire Insight. Certainly one of the first places I go when I'm doing research into anything, and I suspect most of the districts do as well because of that data, in addition to other data like health indexes which are out there. But the combination of presenting the information as it has been today and then following it up with all of the partners round table, bringing back to their organisations what they can do to improve things, is a real model which is occurring at this time. And next time we've got the suicide prevention workshop following on the JSNA from the suicide JSNA. So if you did things in isolation where you just presented information, that would be just a transfer of information. When you combine it with a workshop, you're actually communicating with people as to what you want to see achieved. So I think that is what we do, and that is the train of thought throughout everything we do. There's nothing presented here such that it's like will-o'-the-wisp, it disappears. And
No.
there is a strong ethic behind how we present this.
I appreciate that, and I think the workshop model is fantastic, but frankly it's about an hour. Our workshops are about an hour.
Yes.
After this meeting.
Yes.
And and I think it's a model that's great, and I've said so recently. I do think though we're having half an hour on the next workshop. An hour isn't long enough. If we're really making change to help everybody understand what they can do to take back to their own organisations. So that would be a call from me as a member of this board,
yes,
to say, is there a way of scheduling things so we get more than an hour for the whole enormity of the partners to understand an issue? Because the work that goes into those workshops, they are excellent. They really are excellent, of a standard that I am absolutely impressed by. However, they're rushed. They always are. And I just feel we need to be spending more time on this, Chair.
And
that's my opinion.
How beautiful your timing is when we're at the conclusion of an external review of how the Health and Wellbeing Board works in its interaction with the integrated care service and the new world in which we exist. And one of the main things put forward was, does the hybrid model reduce conversation around the JSNA at the expense of a workshop, etc.? And they are the fundamental questions that we're currently in the process of evaluating, and whether that means that we make it a longer afternoon. It will mean more coffee and more biscuits. But you're actually spot on in exactly what you're saying, because it's exactly what all of us are actually saying at the moment. What is the best model to use the important resource of expertise that we get in this meeting over the coming year? And I think Director Robbins will be aware of that too.
Thank you, Chair, and thank you for that really helpful comment. So I think, as the Chair has just alluded to, we are doing a lot of work around evaluating the effectiveness of the Health and Wellbeing Board, and really thinking around how we take it up to that next level, and how do we really make sure that the work that we're doing here is having the impact. So there's been a number of conversations today about impact, and I think that's a fair challenge that we will hopefully rise to as part of that piece of work. So I'll park that for now, if that's okay, Sarah, so we can pick it up in that piece of work. But the other thing that I would just like to highlight is the JSNA packs that you've got today are almost the first sort of JSNA pack that you've got, which is more in the sort of profile pack, which is a slightly different way that we've presented the information before. So we are trying to think around how we make the JSNAs more accessible and making sure that they're reaching into those really important issues that members of the board are really struggling with, so that we're adding to that evidence base so that we can share it and take it back out to our organisations. Because I think there is something around, there's some really important work that we do in the room, but there's also really important work that we do in terms of taking it back to the ranch and making sure that we're sharing it and making sure that we're really and making sure that the information that is available is shared very far and wide. If people do have any suggestions around how we could make it more accessible or how we can communicate it differently, we are absolutely open to ideas around that. So please do let us know, because we're always keen to make that work better and improve the Nottinghamshire Insight. But I would say that the Nottinghamshire Insight has a lot of information. So I would always see that, as Councillor Doddy's mentioned, around being your first port of call. And if it's not there, then we do have discussions at this board around what are the key topics that people would like to see in terms of a forward plan for the JSNA chapters, because that's something that we all own, not just one of us. So please do, if you haven't familiarised yourself with Nottingham Insight, we can make sure that we put the link in the minutes, so that people do that. And if there are things that you think, actually I'd really like to do a bit more deep dive in terms of that information understanding, then please do let us know, and we can think around how we build that into a work plan for the JSNA moving forward.
Thank you. I'm going to go to Councillor Schuller.
I feel that many of the points that I'm going to raise have been covered, and thank you for the presentations. You talk about more detail out in the communities and reaching out into communities. You talk about the assets within our communities, and what I would like to say is to look towards some of the strategies from the district councils. You do have representation from every area of Nottinghamshire in this board, and each of us provide a strategy for health and wellbeing, and we are the people that are here to advocate for health and wellbeing, and therefore we are here as partners, and we are looking to create strategies that are a systems-based approach, that are building up rich pictures which can inform your work and can actually tell you about the detail within our specific areas, because that's where a Nottinghamshire-wide approach can potentially fall down. We have areas of deprivation, pockets of deprivation in areas where it doesn't look particularly deprived, where in our rural communities, etc. Therefore, we need to be able to fully target all people that are in need. Thank you.
Thanks very much indeed. That was just, I'm sure we all agree with that, that previously we went on a roadshow around the whole of Nottinghamshire, stopping up in the north of Nottingham, Rushcliffe, New York, etc. And in each and every place we went to and asked them what were their health needs and what were requirements, every single place had a different need and a different requirement. So there is no uniformity across Nottinghamshire. In fact, the lack of uniformity is what marks us out. That overall Nottinghamshire always looks good, because on average we are good, but it's the pockets that you have to isolate that need the greatest amount of intervention. And I think, as opposed to having a whole of Nottinghamshire approach, we have a place-based approach now, broken it down into 3 areas. So I think that is the idea, is to have the geographical lens for intervention in the areas of greatest need. Caroline Blues. Caroline?
Hi, thank you for giving me the opportunity to talk, and I appreciate the presentation. As a district councillor for Mansfield, I just wanted to let the area know that what we're doing and some of our things. We've got food clubs and food banks, and I think a lot of people get these mixed up, that we've still got the referrals for the food bank and the food clubs. The statistics that we're collecting at the moment, we have about 160 parcels going out on the food clubs. That's the £1 a year and £3.50 a week. Or if they want, they can do two. Anybody can use it, and we are trying to do what I call the working poor, because we're now getting a lot of people with this poverty that are very good on the credit cards to sort of try and pay the bills. They are working, but they're running out of food, and they feel that they're using. So to get away from the stigma that it's food share, it's, you know, I try and promote it. This food will go into landfill, come and use it. And that seems to get some people in. The other thing that I do personally, I've been volunteering at the Salvation Army in Mansfield. This is mainly gentlemen of all ages, and I would say that 97% of them. And I feel that we've also got to look at what cooking facilities people have, because I think we're giving a broad stroke. And I know one gentleman has only got a microwave, so it's no good giving him fresh vegetables or anything because he can't cook with it. So really, a lot of it is, and I know it's worked for us, is to actually find out how people are living and what they can do. And I can see why people smoke, because if they smoke, they don't get hungry. So they're taking the look at sort of, right, I'd rather have cigarettes or tobacco or vape, because while I've got something in my mouth like that, I don't feel the need for hunger. I'll probably have that and a drink. So it's actually looking at everything as a whole rather than one thing. So I think we do need a holistic approach to this, to food, poverty, because it all comes together. And that's my feeling on the matter, with being on the ground and looking at it's like the Salvation Army. They don't just come in and get a bag and go. They have to have a coffee and a bit of a chat and a bit of a warm, and to build the bridges. So it's not just a dash in, dash out. It's to make relationships. And again, this is, we'll go on to the suicide and thing. It's the mental health and everything else that we do. We've got the social prescribing nurses in as well, and we're making partnerships with the people. So I just thought I'd share that with you.
Absolutely beautiful. That's exactly what we're after, and loneliness is the only one you left out of that list, which is very important. Dawn.
Thank you very much, Councillor. I'm really grateful for you reflecting on the need for taking a whole person approach and putting the person at the centre of that, because as we said, everything is interconnected here, and whilst we've simplified a very complex picture in order for us to be able to engage with it by saying here's 5 building blocks we're starting with, we're very much understanding that we can't tackle those as separate and isolated things. And I think particularly our work around communities will help us come together in that space to actually think around the whole person, and work from, as others have said, what are the real needs within communities, which will vary. So I think some of that work is going to be very important and exciting for us to take forward through things like place-based partnerships and health and wellbeing partnerships at district and borough level. So very much that is our intention and our approach. I wanted to highlight to board members that obviously thinking across even just 5 of these building blocks is an enormous undertaking, an enormous amount of challenge and work that we need to do together. So we're committed to that. But in order to make real traction and progress, what we've said within the papers to you is you raised issues around food insecurity and food clubs, etc. We are focusing particularly on the food plan in the coming year. So whilst we're committed to developing the framework for action across the 5 building blocks, and we will be getting traction on each of those, we will particularly ask members to support us and help us to build a really robust food plan, because that's across the rest of this year, that's our commitment to really focus and get traction in that space, and to deliver on the ideals of the food charter that we've all signed up to. Just wanted to share that approach with you in terms of how we're taking this forward. Thank you.
Thank you, Dawn. We're going to finish with Councillor Tideswell.
Thank you, Chair. In principle, I agree with the building blocks of health and healthy and sustainable places, but there is a slight problem insofar as when I look at the actual problematics, you've got, I know of councils that have waiting lists 1 year, 2 year, 3 years, 4 years, and that is actuality. You know, to find somewhere to live and enjoy in a safe environment. So this has a lot to go before you actually build a safe place to live and work. And that is the actuality we are. I know councils, you know, that have 1 year, 2 years, 3 years, 4 years before you can get a home. And that is the actuality. So I like the councillor behind me. Yes, it looks good, but we need to sort out the facts, unfortunately.
And indeed, housing, one of the basic building blocks of healthy lives, etc. And thank you very much to Viv and Dawn and Carol for the presentations today. We touched on the very bedrock of the whole essence of public health in any language around food and heat, and we're going to touch on even more of them in the coming weeks, etc., and hopefully measure the developments that we procure and the areas in which we're working over that period of time. I'm going to move the aforementioned recommendations to approve the Health and Sustainable Places Framework and those for food poverty and fuel poverty. All those in favour? It's moved, seconded and moved. Excellent. So almost keeping to time, but not quite managing it, we'll move on to the Better Care Fund, item 8 on the Better Care Fund. And who have we got for that?
So I'm Katie Ball, new Director of Commissioning for Adults, taking over from Bridget Cameron, who you'll know, and I do know some people in the room because I used to work in the city.
And I'm Amy Robinson, so I'm Deputy Head of Joint Commissioning in the Nottingham-Nottinghamshire ICB.
Take it away.
Thank you. So the purpose of the report is to ask the Health and Wellbeing Board to ratify the Nottinghamshire Better Care Fund Q3 reporting template, which was submitted on deadline to NHS England on the 9th of February. The Q3 report asks us to report on the 5 BCF metrics, which are avoidable admissions for falls specifically, discharge to usual place of residence, and residential admissions, and reablement, so people remaining at home after a period of reablement. We're on track for 3 of those metrics and slightly off track for 2. These are locally set targets, which at the beginning of this BCF year were set using benchmarking and partners' plans in place to improve performance. So we are very slightly off track, is I think the important message there, for discharge to usual place of residence. And the update from programme leads around that area is this is a discharge from hospital where someone can go home with a package of reablement. Broadly, the number of people being discharged home is trending in line with demand, so we're broadly as a system doing well for that metric. But there is its off track in the BCF report for for the county is that within that group of people who can be discharged home, people with slightly more complex needs who need specific provision around home care, so a slightly advanced level of reablement when they go home. Demand was slightly above capacity, building up to Christmas and over the Christmas period. And programme leaders are telling me that that's around the sort of non-weight bearing type patients, so patients who just need a slightly higher level of reablement support, more specialist skills. And then the other metric that's slightly off track, although very much improving quarter by quarter, is admission to residential care. And in the report it says there that the target for the year to quarter 3 was 399 per 100,000, and performance is currently at 403 per 100,000. So again, we're tracking slightly off our local target on that one, but there are plans in place to reduce the number of people going into residential care, and as I said, the trend is decreasing, just not quite at the level of our locally set target. And then the report also gives you a flavour for a couple of pieces of work that are happening around residential admissions. So South Notts Place-Based Partnership Board recently had a development session, and that included a deep dive into residents' stories, so their whole journey, building into being admitted to residential care, and taking a reflective approach on partnership approaches to early intervention and prevention around that individual. Were there things that all partners involved in that person's care and support could have done differently, could have changed that eventual, or prevented or delayed that admission to residential care? So that's a really important learning session from the PBP that will inform the services on the ground around contributing to that metric. And then also in the report you'll see that NHS England have also now asking for an update on BCF scheme lines, specifically most of them where they have specific outputs, so as in terms of activity, so they ask for now a quarterly update on say numbers of people receiving carer support, or number of people receiving home care, but that's now a quarterly requirement with the BCF, which we are able to provide.
Thank you, Naomi. The purpose of the report is for us to be able to ratify the Better Care Fund quarter 3, which was submitted to NHS England actually on the 9th of February 2024. Councillor Wheeler.
Yeah, thank you, Chairman, and thanks for the report. I just want to, again, be a bit like a broken record, but just put on record again around the disabled facility grants, about the need to be reviewing how we are distributing the funding. I know the funding we get is set by government, but how we portion it out is up to this board and the people who sit on it to make sure we reflect the needs in the community. Because I think what you just touched on about the new reporting, I welcome that. I think it will show where the need really is, and it needs to be based on up-to-date metrics. So obviously in Russia we get the lowest allocation, but actually we're seeing a much higher amount of people who require the support. We put extra money in last year, that's some carried over to next year, just because of the backlog and trying to get the works done in terms of people being released from care, etc. And the knock-on impact of actually helping the NHS, etc. by getting those works done is fantastic. But like I say, that money does need to be allocated based on need, in my view. That's not just for it might be Rushcliffe this year, might be Ashford next year, might be Broxton the year after. It's based on need of the residents. So if I keep pressing that case for asking colleagues and their officers, again, I know it's been discussed at the Chief Officer Forum and other forums there, just to keep working together to look at a better solution for it, just to make sure we do reflect the needs of our community, because it should be my need. Because no matter where you are in the county, if you do need that support, you should be able to get it. And if one district's got money in the bank they can't spend because they don't have the need, another district is having to do waiting list and can't spend it, that's something quite wrong there. Thank you.
So a per capita distribution of funds across an area doesn't always match the requirements of that area and creates inequalities because of the various needs of various parts of Nottinghamshire and the great disparity that exists around Nottinghamshire. Does anybody want to expand on that?
I think just to probably confirm that I've certainly got a person in my team now. He's an interim person, Martin, that I know will affect lots of people in the room and beyond, who is pulling together that. Yeah, he's really good, and he's pulling together that conversation, because that involves decisions across the district and borough councils. So really good that that conversation is starting to happen, and I know that there's kind of a lot of joined up conversation happening. I guess the next stages are look at options, and look at whether people are having to sign up to a certain option or another one, to be able to look at how that funding is used to make sure so many people on waiting lists, etc. Yes, it's a really important part.
So playing.
In people's homes.
Yes. So playing the broken record is having an effect, Councillor Wheeler. So it. Councillor Wilmot.
Yeah, just and the work being done at the moment is really good, you know, and I'm very happy with it. But I just keep hearing from people that their family members have been discharged from hospital because of overcrowding, and not through they should be at home. Is because they need to be at home because there are not enough places in the hospitals, which is, as far as I'm concerned, is a serious situation. And then people are saying that when they get home, some of the care that they get, people to deliver the services sometimes late, and then sometimes they when you get there, they have to go in straight away because they've got somebody else to have to go and see. So they really, it seems not everything's not right, and that makes me a little bit upset that are our residents who need all this help, are they getting the best help? And people who do need 24-hour care and they're not getting it, and then people have falls, which is regrettable, but it's a real problem. How do we combat that situation? If they come in for 2 hours or 4 hours or something, the whole system, it needs to be regularly reviewed to make sure that everyone's right and in an acceptable position. Because, as I say, it just seems to me, and I mean, our hospitals are wonderful. People who keep saying to me this, that, and the other happening, they're still wonderful, but they're overstretched. Which is damaging to the people that are in that hospital. It's got to be, because people are overstretched all the while. So it's just it needs to be reviewed on a regular basis. Thank you.
Yes, thank you, Councillor Wilmot. There are lots of hospitals that have such thing as red days and green days. A green day is when you're in hospital and something productive happens. You have an MRI scan, you have an investigation, and a red day is a day you spend in hospital that absolutely nothing happens. You might not even get a visitor. So they're trying to actually minimise the amount of time, because the longer you spend in hospital, it's actually counterproductive. Some areas trying to get people to dress normally when they're in hospital, so they don't see themselves as being patients in bed to sit out dressed, etc. And psychologically that prepares them to go home. One of the greatest areas that Nottinghamshire County Council is involved in is the discharge to assess. One of the great success stories of things working cross system with the hospital through discharge hubs, preparing people to go home. And although there may be people in hospital who can't get home, the vast majority of those are down to problems with the hospital, and a minuscule amount are down to lack of provision of care by Nottinghamshire County Council. One of the true success areas that the Improve Better Care Fund has been involved in. And it sort of became so important because of last winter and the fact that there wasn't beds available and people were piling up in casualty departments, etc. So great work done on discharge to assess, which Councillor Carlton is well aware of, and that's one of the areas I would say which is an enormous success story, as opposed to otherwise. otherwise. Dr. Bartholomew.
Oh, thank you, Councillor Wilmot. Thank you, Chair. So I agree in terms of there's a lot of work that's happening from discharges. So that if you look at a pathway from a patient journey point of view, that's what we call like the back end of the pathway. So they're already in hospital. What we must be concentrating is actually avoid them getting to the hospital in the first place. And there's a lot we are planning and putting in action. The sort of proactive care, identifying the individuals who are frail, the long-term conditions review, ones who are at high risk of fall. So there's a lot there. That's one of the areas which, again, as a healthcare system, we need to address collectively, working with primary care, working with our community partners in doing that assessment. In terms of the discharge to assess, and there is quite a comprehensive offer in terms of the rehab side of things. But what's more important is being much more proactive, avoiding those individuals going to the hospital in the first place, because there's lots of evidence showing every day that there's an increased stay in the hospital, there's a decrease in one's individual muscle mass, which makes them more dependent on care when they come out of it. So it's important to avoid hospital admissions or get individuals out of hospital as quickly as possible to do that as well. So that's my
Thank you, bearing in mind time. Thank you very much indeed. I move to recommendation, the aforementioned recommendation to approve the Nottingham Better Care Fund Q3 submitted to England on the 9th of February 2024. Thank you very much. All seconded? Yeah, all those in favour? Excellent. I'm going to briefly mention the work schedule, and the next one up is the suicide workshop, which follows on from the suicide JSNA and brings together the people and how they can bring back the important information from the JSNA, as we previously discussed, and give that chain of the presentation of information and then the delivery of the advice within that. And there's been like 19 points that was put forward in the last JSNA. And then after that, probably before we break up from summer, we've got some wonderful stuff around neurodiversity, and I think there'll be a great interest in autism and neurodiversity, etc., with that JSNA when it comes as well. And of course, always happy for people to give us ideas around the workshop, but there's a pattern emerging where we bunch together JSNAs around the same topic, around the same area, present them together, then follow it with a workshop, and that's where we're up to with the work programme. Now, normally before a workshop, I would be delighted to say that there's tea and coffee and some biscuits. I have no such good news this afternoon. In fact, we're not even leaving here, Councillor Wilmot. You're not even getting out of that chair. We're staying in the same chair. We're going to move on to the Nottingham and Nottinghamshire NHS Joint Forward Plan, and we will have Dr. Janine Elson actually presenting on that. And the importance of this is, how does the ICB, etc., do the vast majority of the things that it's required to do, and yet still address prevention and inequality and joint working. As previously said, preventative medicine and demand medicine are uncomfortable bedfellows. Over to you, Dr. Elson.
Thank you very much, Councillor Doddy. If I could have the...
Just 1 minute, I have to formally end the previous meeting. Okay, formally end the previous meeting and start with you. Carry on, Dr. Elson.